wouldn't work, it was because local leadership had, up to that point, largely demonstrated that they were under significant political pressure not to accept measures. Now, there were exceptions to this. For instance, the mayor of Liverpool, Joe Anderson, not the mayor of the Liverpool City region, who I know has been a witness, Joe Anderson, unfortunately, no longer with us, he was incredibly supportive, and we ended up in Liverpool having a package of measures that was effective after a very constructive negotiation and discussion, and in a spirit of collaboration. Despite, I mean, he was a Labour mayor, the parties really didn't matter at this point.
Right.
But others were not constructive, and in some cases actively unhelpful, and I felt put politics ahead of public health.
And I don't want to go into the detail of it, but it's right that we acknowledge that. Is that what the entry in Sir Patrick Vance's diary is to? There's a reference to Manchester and the very difficult negotiations that went on in relation to Manchester.
Yes, I would say that the diary entry might be better written as political leadership in Liverpool and political leadership in Manchester. I've got no beef with the fine city of Manchester.
Your statement makes plain that as the end of October approached, you weren't winning the argument for a national lockdown. You therefore took the step of asking health leaders to make the case for a second national lockdown.
Yes.
It is self-evident. Was that necessary?
Yeah.
Because you felt you were losing the argument?
I felt like there was. We were in a campaign to win the argument, and others were using. Whereas up to this point, I'd essentially argued internally. At that point, I decided that those who were against action, which I saw as extremely dangerous, were using public debate and trying to win the debate in the discourse, and I therefore got I corralled the voices that I knew would support what was needed in the public health interest. So I spoke to the Royal Colleges, I spoke to different parts of the health system, and I said to a system which is normally very, it's actually remarkably hierarchical, the health system. And I said, get out there and make the case, get out there and explain what will happen if we don't take action now. And boy, they did. And because everybody I don't know a single voice in the health and social care system who wasn't in favour of more action at that point, because we could see what was going to happen.
129555 is a WhatsApp communication between yourself and Simon Case. And you say in terms, and this is the 30th of October, Mr. Hancock, so obviously there is enormous debate and very difficult debate in government as to whether or not the second national lockdown should be imposed. I think it may be the second page.
I think we decided by the 30th of October.
Well, the reason I'm asking you is you say Rishi is in the room, contrary to the stupid rules, so the Prime Minister will be under enormous pressure to not do enough once again.
Yeah.
And so given that that's the 30th of October, my question, in fact, is, was that a reference by you when you say to not do enough again, once again, the decision to make the lockdown?
Well, the stupid rules is that...
No, don't worry about the stupid rules.
Okay. But I was not allowed physically present into this meeting.
To not do enough again. That can only be a reference to the debate about the lockdown, presumably.
Yeah, so I'd been blocked from going into this meeting, and you can imagine who made that decision. The Prime Minister would be under pressure not to do enough. So repeatedly we had taken action, but it wasn't enough to get R below 1.
But on this day, the 30th of October, and you're aware, of course, that there'd been a forward strategy meeting in Chequers on the 25th of October.
Yeah.
The COVID task force had forwarded an advice seeking a lockdown on the 28th of October to the Prime Minister.
Yeah.
And they'd presented a further paper again on the 30th of October. And then, as you'll recall, there was a further paper prepared for the COVID-O on the 30th of October. This can only be a reference to that debate which was going on the very same day about the national lockdown.
Well, around this time, we did make the decision for a national lockdown. It may have been that this message was during the decision-making meeting. You can read it that way.
At the bottom of the page, Mr. Hancock, you say, "I can live with that." That's a reference to a question about non-essential retail and secondary schools. But I'm very worried about a rearguard action that has screwed us all over too often. What was the reference to rearguard action? But what were you referring to there?
I was referring to the Prime Minister making a decision in principle to take action that was necessary to save lives, and then others arguing strongly against it afterwards. And I don't actually know who the others were, because I wouldn't have been party to those conversations. But that was something that we'd lived with.
And of course, as you explained yesterday, as the Secretary of State for Health and Social Care, your primary concern, perhaps your only concern, had to be the public health clinical side of this terrible debate about the second wave, bringing R below 1, and of course the damage to the economy and the societal harm that would be wrought by another lockdown.
Well, obviously, as you've seen from all of my evidence and all of the contemporaneous evidence, my primary concern was saving lives and making sure that we got through this with the NHS not being overwhelmed and as few people victim to this horrible virus. That was throughout the whole period, that was my primary motivation. And this inquiry has brought evidence that I didn't even know about myself, that demonstrates that the work that was going on with the health system as a whole that I led, and me obviously putting my voice to that. But, and this is a crucial point, as an MP, as a member of the cabinet, I didn't only care about the health interest. The importance of the economy matters too, and that would have been more damaged by delaying, and indeed was, because we had to have a tougher lockdown. And as I've said, I think if we'd managed to bring in an earlier lockdown, we may not have had to close schools second time round, as we did, because the case rate got so high. We again, in January, had to pull every lever, as we'd had to in March 2020. And so it is it isn't just that I was interested in the health outcomes. That was obviously my primary duty and my primary responsibility and my primary concern. But it's broader. My argument was broader than that. It was that even if you care only about the economy, you need to take the measures early, because there's absolutely no way we're going to allow R to be above 1 until case rates get to a position where the NHS is going to be overwhelmed, and that is always going to be the case until we have a vaccine.
And is that why, essentially, in your witness statement, you say there were no excuses second time round? Clinically, in public health terms, there was simply no proper debate against the imposition of a second national lockdown. Economically, a second national lockdown imposed earlier would have less effect, overall damaging effect on the economy. So as it seemed to you, the arguments were all one way.
Yes, and that was true. And the more you thought a vaccine was going to come, the sooner you thought a vaccine was going to come, the lower the validity of any argument the other way. And at this point, I was highly confident that a vaccine would come. We'd seen the animal trials and the phase 1 trials on humans, but by October there was a quote brief from somewhere in Whitehall saying Matt Hancock is the only person here who thinks there is actually going to be a vaccine, said a Whitehall source. It's a running joke with other departments. But I was looking at the evidence, by the way, which was publicly available, that there was going to be a vaccine. To give him his credit, the Prime Minister always thought there was going to be a vaccine as well. And I'd tasked the NHS on being ready to deliver a vaccine from the 1st of December as the reasonable best case scenario. It was nice to be able to talk about reasonable best as opposed to reasonable worst case scenarios. And in the end, we started on the 8th of December. But that's important for these considerations, because if you think a vaccine is coming with any degree of confidence, then all of the arguments about resisting lockdown measures fall away, because the action that you're going to have to take will be temporary. If you think there's never going to be a vaccine, then it is a much more difficult conundrum. But by now, we were pretty. Those close to it were pretty confident there was going to be a vaccine.
And so, for all those reasons, the position you reached was that the argument strongly favoured an earlier lockdown than was in fact imposed, and there was no real argument against the imposition of a lockdown, second national lockdown in principle, for all the clinical and economic arguments to which you've made reference.
Correct.
Right. You weren't, I think, your statement doesn't suggest that in relation to the third lockdown, you had any real doubt about the wisdom of its imposition. Clinically, in public health terms, and presumably for the same reasons, the economic arguments, there was no option but to impose a third national lockdown.
Absolutely. And by that stage, because the case rates were so high, we again had to pull every lever, which included, unfortunately, having to close schools.
And the prevalence rates were so high, in part you describe, because the November lockdown had not been long enough, it had not been imposed early enough, and also you thought that there were very real mistakes in relation to the regulations which had been put in place in December and over Christmas. They'd all contributed to the high prevalence rate.
Well, there was an additional complicating factor, which was the alpha variant, which was more transmissible, and therefore by then we'd come to quite a good calibration of what MPIs you need to keep R below 1, and we'd got to the point where that was embedded within the tiers system. But unfortunately, the alpha variant blew those calibrations because it transmitted faster, but we didn't know exactly how much faster because it was a new variant, and so therefore we had to pull every lever. And I remember after we'd made the decision, I think it was on the 4th of January, to go into another full national lockdown, I remember the 2 weeks after that as harrowing, because the case numbers kept going up as they had in March after we'd pulled every lever, and there was nothing more we could do. And because this was a new strain, again, we didn't know whether everything would be enough to get it under control. And thankfully, we did get it under control just before the NHS was overwhelmed once again.
Because of the perennial debate, the overriding imperative, as you saw it, to bring R below 1 because of all the terrible consequences.
Yeah, not just as I saw it, as logic requires.
I'm asking you the...
Yes.
Just please now, finally, Mr. Hancock, one or two concluding and disparate issues. Can I make plain that I'm not going to ask you any questions about 2021 in large part? The inquiry has, of course, your very detailed witness statements, which deal with the salient features of 2021. But just two or three small areas. The inquiry heard evidence from Professor Ferguson, how he resigned as an advisor to SAGE on account of his transgression. At the time of his resignation, you were asked if the police should prosecute him. You said rightly, it's a matter for the police, it's an operational matter. But you made the point quite rightly that these were important issues and the social distancing rules were important. You obviously transgressed yourself, and that came to light in June 21, on the 25th of June. I'm sure you acknowledge the incredible offence and upset that was caused by that revelation. In terms of the impact on public confidence, there were a number of transgressions in public life. Overall, do you think that those breaches had an impact upon the public's propensity to adhere to rules? And acknowledging, of course, that by June 2021, we were out of the worst. There was, in May 21, the tail end of the regulations and guidance in place. But overall, it was damaging.
Well, what I'd say is that the lesson for the future is very clear, and it is important that those who make the rules abide by them, and I resign in order to take accountability for my failure to do that.
And that, to your credit, must have been in reflection of the fact that you understood the importance of, or the deleterious consequences of rule breaking or guidance breaking on public confidence and the public at large.
Yes.
All right. Long COVID. Your statement makes plain that from an early stage you asked NHS England to consider what could be done, and you asked Simon Stevens to develop plans for addressing the issue of long COVID. From your assistance to the promulgation of NHSE guidance in June and the announcement in July by the National Institute for Health Research and UK Research and Innovation, and also your convening of a roundtable in July, it appears very clear that you were alive to the concerns about long-term sequelae from the infection.
I was alive to it from before the infection reached our shores. Chris Whitty raised the concern about the potential of some kind of post-viral fatigue syndrome, which happens with other viruses as well. And then after the first peak, I was acutely aware of it, not least because members of my family were affected by long COVID, including my mother, who still attends a long COVID clinic. So this was very close to my heart.
To what extent, when you and your colleagues became aware of long-term sequelae and the long-term consequences of infection, did that understanding feed its way into the debate about the mechanics of non-pharmaceutical interventions and then subsequently the relaxation of restrictions? What role did, or to what extent did the issue of long COVID play out in the debate about the mechanics of NPIs?
Well, it matters, of course, because it makes the virus even worse. It makes the impact of the virus even worse. And so it reinforced the arguments that we were making already. Of course, the best way to avoid long COVID is to take the measures necessary to reduce the amount of COVID, full stop. And so it actually calls for the same policy prescription in terms of preventing COVID and therefore tough NPIs to keep R below 1. But it also required more research and support from the NHS, who found it quite difficult because it was a new disease and because of its nature presenting in many, many different ways. They found long COVID quite difficult to categorise at first. And so with Simon Stevens, we worked together to bring forward long COVID clinics that could look across the range of conditions that are loosely gathered under the term long COVID. As I say, I cared a lot about this for personal reasons as well as professional reasons, and we didn't need sign-off from the centre. We just got on with it.
Do you happen to know why, notwithstanding the considerable amount of work done on long COVID from the very early days and throughout the summer, particularly of 2020, the public campaign about long COVID wasn't launched until I think October? Do you know why there was that potential lag in the communication side of the debate?
Yes, I think it was essentially because understandably the clinicians found it hard to get a handle on exactly what the term meant at first. I knew what it meant, and those suffering from it knew what it meant. But turning that into a formal protocol would normally have taken a lot longer, but it was one of those things that happened. It took some months for the clinicians to put it together. I think we decided to do that was it June or July 2020, at that roundtable meeting that you mentioned.
The 31st of July, yes.
31st of July, which I'd convened. And so it was put together in around 6 weeks from then. So although that looks slow in the context of the pandemic, that is fast in the normal context of medical response to innovative problems.
Particularly the public-facing side of the medical response.
Yes, and clinicians understandably wanted an answer to the question, what exactly is long COVID, before they would go out and say that we're having a campaign on this. So that was a piece of work. Of course, I wish it had gone faster, and I was pushing it, but nevertheless, I can understand the reasons it took as long as it did.
And finally, in relation to disparities, your witness statement makes plain that you were obviously aware from a very early stage on the clinical vulnerabilities or disparities from coronavirus 19.
Yes.
You were aware of the risk factors from a very early stage.
Yes.
You were, of course, aware, and you explain how you became aware of the terrible figures showing disproportionate numbers of black people and black and minority ethnic healthcare workers being hospitalised.
Yes.
and ultimately dying. And you contributed to the process by which SAGE and other bodies from April onwards looked at this issue. Did you also commission work through Public Health England? There was a rapid review, I think, on the 12th of May, then a full review on the 31st of May. And then did you also contribute to the decision that further work and the reports be ultimately commissioned through Kemi Badenoch?
Yes. I was particularly struck by the death of the first 4 NHS doctors, 3 of whom were from an ethnic minority background. I was acutely aware of the disproportionate impact on those from ethnic minority backgrounds, especially amongst the wider NHS workforce as well, not just the doctors and nurses, but also more broadly, including porters and other staff who do vital work and often are very closely in contact with patients. So this is something that I was worried about from early in the pandemic. I'd in fact worked on this before the pandemic, including raising the issues of discrimination within the NHS, and there was work underway on a particularly difficult issue that came up in NHS BT. So there was a wide range of work on this. I was aware of it from the start, and I was very glad when Kemi was tasked by the Prime Minister to lead and really get to the bottom of this.
To give me one minute. My lady, those are all my questions for Mr. Hancock.
Thank you very much. Right, Ms. Morris, you going first?
Thank you, my lady. Mr. Hancock, I ask questions on behalf of COVID Bereaved Families for Justice UK and COVID Bereaved Families for Justice Northern Ireland, who sit behind me. And together we represent over 7,000 bereaved families, bereaved by COVID, many who sit behind me, and many who have lost families in care homes. So my questions are centred at a high level on the decision on the 19th of March to discharge untested hospital patients into those care homes. Yesterday, you accepted an evidence that on the 15th of May 2020, in a press conference, you said that right from the start, we tried to throw a protective ring around care homes. So the context of my questions is to probe with you your claim that you'd taken those steps right from the start or
Yes.
at all.
Yes.
So I'm going to take you through some of the key dates at the start of the pandemic and examine what was known or ought to have been known by you and your department and how that informed the decisions that were made on the 19th of March. Okay? Can we first have on screen, please, INQ 49363, page 2. And this is a minutes of an adult social care coronavirus meeting. Thank you. And it's action 3, please. Can I just switch that? Thank you very much. I'm just going to move my... Thank you. Says that there was noted at point 7, this is the 11th of February 2020, it's commented that there were likely to be 3 ways that the virus could enter a care home: infected people moving into homes, staff and visitors, and that these should be considered during the response phase.
Yes.
So the question is this: what was done to minimise those 3 different routes of infection prior to the hospital discharge policy on the 19th of March?
Yes. So this document is from the 11th of February.
Correct.
For context, there were under 5 cases in the UK at that point. So this is very early on in thinking about how we are going to handle the pandemic. But it was clear from this point that the virus had its biggest impact on those who are older and had underlying vulnerabilities. So we knew that there was a problem, and we knew there was a significant and specific risk for those who lived in care homes, and in particular care homes that looked after older people.
And in particular, these 3 ways present 3 potential breaks to any circle or any ring of care. Is that fair to say?
Yes, absolutely. And we considered these from throughout in terms of how we could best support and protect people in care homes. In fact, the work had already started before this, and we had the first Adult Social Care National Steering Group, for instance, on the 5th of February.
Yes, and I'll come back to some of those steering group minutes later. Next, I've put on screen, please, INQ 74910, page 2. This is the 24th of February now. Mm-hmm. This is a PHE response to a question that's been proposed to them. If there's an evidence of cluster of COVID-19 cases in the UK, what will the PHE proposal be? It's under 2A, the second heading there. Could that just be highlighted and enlarged, please? Thank you. It says, if there's an assumed outbreak of 5 to 25 cases, the PHE advises that no discharges be made from hospitals to care homes whilst there's a cluster of cases in a hospital during the containment phase. Maybe a little further down the 2A section there in terms of the highlight. The highlight could just be expanded or lowered down, please, just to highlight the bottom of those bullet points. I'm grateful. Yeah, it's in the middle of that paragraph. No discharge to residential care homes. Middle paragraph of 2A. So on the 24th of February 2020, the PHE are making it clear there should be no discharge to residential care homes because of the risk of infections that would create. Is that correct?
I didn't see this document at the time, but my reading of the document as you presented it to me is that in the case of an outbreak in the care home, then there should be no discharges to that care home. That's my reading of it, but this is a PHE document that I wasn't aware of, so it is as it is. The evidence is there.
Thank you. You've mentioned the National Steering Group meetings. They took place in February, and 2 in particular, the 19th and 26th of February. I'm going to suggest have been expressing serious concerns about the availability of PPE in care homes. And in particular, we can go to them if you'd like to, but I'm going to suggest on the 26th of February, there was hard evidence of PPE stock being requisitioned by for NHS use. Is that correct?
I'm not aware of that, but if you want to put up evidence showing that.
Okay, so
What I would say is that on PPE, at the end of, it was obvious from January that was going to be a problem with PPE. At the end of January, I agreed to the recommendation that we should release the PPE stockpile, and I also requested that we started buying PPE in size, as in large scale, which we did. It was a global challenge because suddenly everywhere in the world was trying to buy PPE. Also, there's another structural point which is really important here, which is that care homes and all of social care is legally responsible to local authorities. It is commissioned by local authorities. And so there's a structural problem, which is that the responsibility and policy questions inevitably, especially in a crisis, flow to the national government, but the levers, the policy, the formal policy, and all of the legals are in the hands of local government. And so we started this with a social care sector, in need of reform, where the reforms hadn't happened, and where the formal legal responsibility was for local authorities.
Understand that, but what I'm asking you about is what was known by your department about methods and equipment that could keep care home residents safe.
Absolutely.
In terms of how you then set your policy and what you dictate should happen. Okay, so let's look at those steering group minutes together, please. INQ 114887, specifically on this point about the NHS requisition. It's page 2 again, and it's the top action on page 2, please. Action. Concerns about NHS 111, and it says under first bullet, hard evidence of providers failing to get PPE they'd paid for as its requisition for the NHS. Now, don't need to dig too deep beneath this in terms of logistical matters, but it's clear there, isn't it, that the department is aware from stakeholders that there are not only concerns about PPE, but there's difficulties in getting what they've paid for.
That's what it says.
Okay, thank you. So by the end of February now, that's the 26th of February, that set of minutes, I'm going to suggest that it's obvious to your department that care homes were a vulnerable population. I think you've already agreed with that.
Absolutely, yeah.
With multiple sources of infection, you've agreed with that, and real problems, I suggest, with obtaining PPE. Would you agree?
Yes.
So moving into March, you told Mr. Keith yesterday that Helen Whately had come to the very firm view, on or around the 2nd, that plans for the care sector were non-existent or inadequate, were your words, and she was messaging you about that.
The 3rd,
yes. And in early March, Miss Whately also had concerns, she says in her statement, about an inability to obtain timely and accurate data about COVID-19 deaths in the care sector.
Yep.
In stark contrast to the data available in the healthcare setting.
Absolutely, yes.
So what was done, if anything, in early March to rectify this lack of data?
Well, we acted to try to make sure that PPE got to care homes and took action on that front, not least responding to the concerns that have been raised by the sector. And in terms of data, gathering data was extremely difficult because of the lack of a direct relationship, contractual relationship between the department and care homes, unlike the department's direct relationship with the NHS.
Okay. Touching on PPE again, you've said in your statement on the 5th of March, Miss Whately also continued to warn that PPE provision in care homes was inadequate.
Yes, she was very worried about it. She met the chief social worker on the 4th of March as well to discuss the concerns around the preparations in care homes. What this all demonstrates is as much action as possible from the top of the department to try to solve these problems, which ultimately were started with the structural makeup of social care, which is a decision that can trace its origins back to the foundation of the NHS in 1948.
As we'll see later from another document, in fact, PPE was only sent out to care homes on or around the 19th of March, the same day that the discharge of thousands of patients was ordered. But I'll come back to that. Chronologically moving forward to the 6th of March, you open a departmental meeting on social care. We can have that on screen, please. INQ 49530, page 1, and it's the first bullet point, please. Thank you. Secretary of State opens the meeting by stating the impact of coronavirus, which poses a complicated set of problems on the social care sector due to the higher risk for older people and the need to be gripped as soon as possible.
Yes, and what this and the cast list demonstrates is the seriousness with which we took this concern and this problem, because you have me, 3 junior ministers, Jenny Harries, who's and Jonathan Van Tam, so 2 of the Deputy Chief Medical Officers, and the Permanent Secretary of the department. So this is a very 4 junior ministers, because Lord Bethel's there as well. So this is essentially me gathering together the leadership of the department to state in no uncertain terms, as you can see, the concerns that I had around this, that we had around this, and to work out what best we could do about it.
It says it needs to be gripped as soon as possible.
Correct.
Mr. Hancock, if you've been trying to grip from the start to throw a protective ring around, why hadn't it been gripped before the 6th of March?
This is a departmental meeting. The official position of the government going into the crisis was that care homes are contracted by local authorities, and as you'll see in some of the earlier documentation, that the role of the department is around policy over social care. And the contractual arrangements are local and don't report into us.
Okay.
What happened was that in early March, Helen Whately brought to my attention on the 3rd that she didn't think enough was being done through local authorities, the local resilience fora, which were the formal places where it was supposed to be done. And therefore, we called a meeting 3 days later. So this demonstrates the department getting stuck in because not enough was happening.
So you're concerned that not enough is happening. You're,
yes,
as you say, trying to take a grip of it as soon as possible.
Yes.
Moving forward to the 9th of March, please. This is now going to be a COBRA set of minutes, INQ 56219, page 5, please. And it's point 5 in highlight when we get there. Thank you. CMO says there are 3 stages of intervention with varying individual and combined efficacy. 1, self-isolation of symptomatic individuals. 2, full household isolation where 1 individual is symptomatic. And 3, and significantly, a series of currently undetermined measures to safeguard the elderly and vulnerable individuals.
What date was this?
It's the 9th of March, Mr. Hancock.
Mm-hmm.
So the question is, why, given the information you and your department had by the 9th of March, were the measures being described in this COBRA meeting to safeguard individuals, elderly and vulnerable, including those in care homes, being described as undetermined?
Because at that point, we were putting together the shielding programme, which was ultimately extremely successful. And the evidence is that those who were shielded were half as likely to die of COVID due to the shielding measures. That's some external research that's been done since. So clearly, this was a very important area that we were working on. At this point, on the 9th of March, there were fewer than 2 deaths in the UK. So we clearly needed to be doing the work, and we were.
So between the 9th and the 17th of March, when the NHS written direction to hospitals came out stating that beds should be emptied, what concrete steps were taken by the department to put in place strict protective measures for care homes specifically?
Well, we issued guidance, and we also, as you said, issued or at least made the decision that care homes should receive free PPE. Most care homes are private organisations and hitherto had always bought their own PPE, and we decided that they should get free PPE. So there's 2 examples.
The guidance you mentioned, it being the 13th of March.
13th.
OK, we'll come back to that. But just to continue along chronologically, the 10th of March 2020 is the first notification of an outbreak in a care home, so the day after this COBRA meeting. The 17th of March, the NHS written direction to hospitals was issued. On the 18th of March, according to a PHE report compiled later on the 1st of June, care home mortality data had been reported to you as part of a SITREP, the DHSC, and to yourself. But 19th of March, the key date, I'm going to suggest, so just 9 days after the first notification of a positive case in a care home, the 10th of March, the PHE was aware of 37 outbreaks in care homes.
Yes.
And I take that from a set of INT meeting minutes, INQ 119476, page 4, please. It's under the bold heading CROC in the middle, and those bullet points, please, if they could be highlighted. Thank you. So nursing home outbreaks, as of yesterday, this is the 19th of March, we're talking about the 18th, in fact, 37 ongoing outbreaks. All healthcare protection teams are getting multiple calls from care homes. These are likely to result in deaths over the next 3 to 5 days. You also see the bottom bullet point there. There are 24,000 care homes in England. Delivery of PPE is starting today.
Yes.
This is the free PPE you've touched upon a moment ago, being sent out from central resources to care homes, yes?
Yes.
So this is the day, the 19th of March, when it's known that there's 37 outbreaks, that the guidance is issued to discharge patients from hospital to care home settings without any testing in place.
Well, the testing capacity was much too small at this point, and
you've accepted that yesterday, and that's helpful. But given that the testing capacity was too limited to be able to test any of those hospital patients due for discharge, what other concrete measures were put in place to ensure that stringent infection controls was present in care homes?
Well, that was set out in the document that was published, which was based on clinical advice. And yesterday we discussed the matter of asymptomatic transmission, which is important here, because that clinical advice was based on the presumption that the transmission mechanism of COVID was the same as the transmission mechanism of SARS, because there hadn't been at that point concrete evidence that the clinicians making that advice at PHE were confident in to change that assumption.
Okay. But without testing anybody, Mr. Hancock, you don't know whether they're positive or asymptomatic or negative.
Indeed, but we didn't have enough tests at the same time as this. This is, I think, 19th of March.
It is.
On the 17th of March, I had taken responsibility for testing from PHE into the department because it wasn't growing fast enough. So I knew there was a problem and I was acting on it.
And you knew there was a problem, but still issued that directive for those patients to be discharged from hospital.
Well, that's because if we'd left them in hospital, they were more likely to have caught COVID because of the risks of nosocomial infection. And as the Gardner case found, it was rational and reasonable to make sure that they were in the safest place that they could be. I fear, and there are only choices between bad options here, I fear that if we had left those patients in hospital, those who were medically fit to discharge, there is a high likelihood that more would have caught COVID and the problem could have been bigger. So, I have gone over and over in my head the decisions that we took, and save for the point about asymptomatic transmission, which we went over in detail yesterday, every decision was a choice between difficult options, and nobody has yet brought to me a solution to this problem that I think, even with hindsight, would have resulted in more lives saved. And you can put as many, and if there is one, I want to know about it, because it's crucial that we learn these lessons for the future.
I'm afraid we're going to have to leave it there, Ms Morris. I know it's a really important issue, but we will have a module dedicated to care.
I appreciate that, my lady.
I'm afraid we're going to have to leave it there.
May I just address one document, Mr. Hancock, because he's raised the matter in terms of the guidance that was issued to care homes, if I may. The 13th of March guidance he mentioned. Mr. Hancock, just to clarify with you, that guidance issued to care homes didn't state that they would expect to have any isolation facilities at all. There was nothing in place, was there?
Well, that guidance was based on clinical advice, and it was published at the time.
That's it, I'm afraid. I'm so sorry, but we've got a lot of questions to get through. as I say, we will return to this very important subject in another module. Ms Harris. Can you see Ms Harris? If you look round
Yes.
the pillar, Mr Hancock.
Yes, thank you very much. Good morning, my lady. Good morning, Mr Hancock. I appear on behalf of COVID-19 Bereaved Families for Justice Cymru, representing bereaved families in Wales. And I'd like to ask you some questions within the time I have available to me, and I'll stop when my time's up, regardless of how far I've got. And those questions are about care homes, again, I'm afraid, and also about arrangements for relations between the UK government and
Yes.
devolved administrations.
Yes.
First of all, if I may touch on another matter relating to care homes, the same general theme, but specifically with regards to movement of care home workers between care homes. And we heard about that yesterday, and I'd just like to pick up on one further point with regards to the timing of the intervention that there was from the Department of Health and Social Care through your initiative in May, mid-May of 2020. If I could just briefly highlight a few points about the evidence so far on this issue. Yesterday, you referred to there needing to find a balance between what you referred to as two unpalatable outcomes, and referred to there having been worries about not having enough staff in care homes. And you obviously mentioned the guidance or recommendations which were brought in mid-May 2020. So action was taken in this area then, which included also an infection prevention fund. So there was also financial support that came in at that time.
£600 million and also the relevant support for the devolved administrations.
Thank you. And in your witness statement, you have highlighted, and you've, of course, made this very clear in your evidence generally, that very early on, and you state from January 2020, we considered that care home residents were some of the most vulnerable to the virus.
Yes.
That was clear from the outset. And if I could just highlight one other point, a general point as well here at the outset, you have mentioned the division of responsibilities for this sector, and that there was a certain complexity around that.
Yes.
Because the levers, I think was the way you put it, were in the hands of local government, local authorities.
That's within England and, of course, devolved.
Thank you. And that care is commissioned by local government,
Correct.
Local authorities. But it is right, of course, and I think you have acknowledged this, and it's also stated in the witness statement of Sir Christopher Walmold, where he sets out these structures, that, of course, the Department for Health and Social Care is responsible for national policy.
Yes.
Yes.
And for things that only the centre can do. I think that was the phrase that we used to describe where our responsibility rightly started. In the end, we took more responsibility than the formal policy at the start. But at the start, the idea, or in normal times pre-pandemic, the idea was that the responsibility of the department is for policy and for things that only the centre can do.
Yes, thank you. And then just to highlight the further key points in your witness evidence, then, in your third witness statement, you've dealt with this issue quite specifically, and you refer to identifying the movement of staff between care homes as a vector for transmission.
Yes.
That's your phrase. And you say that the moment this became clear, I pushed hard to limit and then ban staff movement. Various arguments were presented, including that staff were essential for the sector, which of course they are, but I took the view that the need to stop infection getting into care homes was more important.
Yes.
So those are your words. And then you refer then specifically to the care home support package and the funding support that was made available and guidance, further guidance in June 2020.
Yes, although it's worth saying that infection control fund first launched in May 2020 and then added to later, also funded, and I think primarily funded, the support payments for staff who were ill, because there was evidence afterwards, and it's intuitively clear that if you pay staff when they are ill, then they're less likely to go to work if in doubt, and that was an important way of reducing the ingress of the virus into care homes.
Thank you very much. So the guidance and the funding that came in mid-May was important in those two respects.
Two ways, yeah.
Thank you. You have, and just to complete the aspects of your evidence I'd like to highlight, you say in your main witness statement that the action that we took to restrict staff movement reduced infections significantly, and that it is a vital lesson for the future, for
Yes.
future pandemics, and indeed for normal times.
Yes, so I think this is important for containment of flu, for instance, in non-pandemic times. It's important to know that staff working in more than one care home increases, in some cases significantly, the risk of communicable diseases. Vital in pandemic times, but important given the risks that communicable diseases like flu pose to care home residents in normal times too.
Thank you. And to come to my question, and you have indeed already highlighted that as at early March, there was a concern about getting to grips with this sector.
Yes.
I think that's fair.
Yes. You know, when in early March it became clear that the formal government processes, which was how the relationship with care homes was meant to work, when it became clear that not enough was being done, as you can see from the documents that have just been shown by the previous in the previous discussion, we threw ourselves at this problem. Yes.
Yes. And I think what my question is really directed at is not enough being done and how that arose. And we understand that there was the structural complexity in this area. But given the vulnerability of the sector, which was known,
Yes.
and of course the overarching role that the Department of Health and Social Care has in relation to this sector,
Yes.
wouldn't it have been right for the department to be looking with greater focus at this sector, given that what was on its way was unprecedented, that it was really should have been anticipated that they would need some help and some intervention at a national level?
But it was anticipated. The first Adult Social Care National Steering Group was on the 5th of February, only shortly after we understood the characteristics of the virus and its greater impact on older people. So the answer to your question, of course, is yes. And knowing everything we know now, would you go back to February 2020 and do more? Of course, but at the time we were engaged with the sector. You've seen the minutes of the meetings, and then it became clear that that we needed to put more effort in, and we did so.
I see.
So it was brought. I was doing my duty on this, and then it was brought to my attention that we needed to do more than we were technically responsible for, and that's what we did. That's what that 6th of March meeting is all about.
Thank you. But in terms of the idea of doing more than you were, as a department, technically responsible for, it's right, though, isn't it, that in terms of issuing guidance and also initiating, bringing in a new pot of funds, which is what did happen on the 15th of May, that's not outside the role of the department. That is actually what the department is supposed to do. That is its role in relation to this sector.
No, it's not its role. The department's role in normal times is not to fund the care home sector. The care home sector is funded by local authorities, and when there's national funding, it goes through MHCLG rather than the Department for Health and Social Care. Indeed, we put 1.6 billion into social care via the NHS on the 19th of March, and you'll see from the paperwork around that decision that the route through which we put that money in to get it in fast was unprecedented. And when we took that proposal to number 10, they said, we're in favour, but you need to make sure that Treasury and MHCLG are supportive of using this approach because it's novel. So I reject the proposal, the point that it was our job to do that. We, in fact, invented new ways of getting money to care homes in the same way that we gave free PPE where all the time in the past PPE had been bought by the care homes themselves because they're largely private sector. And in fact, we put in extra money in March, in April, in May, and so on. So, of course, I understand the impact on care homes. You know, I understand that very personally. We did, once it was brought to my attention that not enough was being done, I corralled the most senior people in the department, and we threw ourselves at this problem.
Thank you, Mr. Hancock. I'm grateful for those observations, and as I know you're aware, this is a subject, of course, which will be looked at in more detail in
Yes.
the later module. So I'll move on to my next question, and this is in relation to the subject of the co-working between the four nations.
Yes.
And first of all, with regards to the understanding there was of what was meant by a four nations approach,
Yes.
and how this was understood across government. And it's a short point, but I think it's easiest dealt with by calling up a document, INQ 0002333806. And I hope that will appear on your screen. Thank you. And this is a document that you exhibited, which is a script which was provided to you when you were asked to call members of the Cabinet ahead of a Cabinet meeting on the 10th of May, which concerned the proposals for the move out of lockdown. You were provided with this script, and this told you what you were being asked to say to other Cabinet members in advance of the Cabinet meeting with regards to what those proposals were.
Yes.
And it's useful because of what it says about the understanding of a four nations approach. So it's just that short point. And if you could go, please, to the bullet points, you will see that it, first off, explains that the government, the Prime Minister, is going to set out a roadmap for the months ahead. This is the roadmap out of lockdown. And then at the second bullet point, following that call, the PM will have a similar conversation with leaders of Scotland, Wales and Northern Ireland at Cobra to ensure that we have a four nations approach to our response. Part of the four nations approach is the flexibility to respond to the needs of particular parts of the UK. And so the devolved administrations will take their own decisions in accordance with their devolved powers. So noting the references there to a four nations approach and to the anticipation that the four nations would take, in fact, a different route, but nevertheless within the concept of a four nations approach, does it accord with your understanding of a four nation approach, that it does signify not just when the four nations act in a uniform way, but also when they may take a different route? And in those circumstances, a four nations approach would imply coordination, cooperation and communication between them, whilst they may not be doing exactly the same thing.
Well, obviously, I strongly agree that communication and coordination between the four nations was important, and I enjoyed, and I mean that literally, I enjoyed the relationship that I had with the other three health secretaries of the devolved nations. We had a weekly call that I instituted in March 2020, and it became a bit like a therapy session, frankly, because all four of us were facing very significant challenges, and we would talk to each other about our challenges, and whether it was in respect, for instance, to care homes, which you mentioned, where Scotland had a bigger problem than we did, or whether it was to do with PPE, where the distribution physically across the UK was a challenge, or of course the rollout of the vaccines and the testing system, which was part UK and part devolved. We had a very constructive relationship, and I think these bullet points reflect the reality that particular parts of the UK had their devolved powers. Now, notwithstanding all of that, and my basic approach of bring in the devolved health secretaries and a high degree of trust between us, and you can see that from Vaughan Gething's testimony, for instance, INQ 269372. I don't propose to put it on the screen, Chair, but there is testimony from the devolves about the warmth of that relationship, and I thought we should just get them into COVID-0 and have the discussion all together. However, having said all of that, I still don't think for the future that it is necessary to have or logical to have devolved powers for handling communicable diseases, because the administrative boundaries, particularly the Welsh border, it doesn't stop human interaction at all. I mean, the Welsh border roads meander into England and Wales. You only have to go to Chester Football Club, where the entrance was in one country.
If I could bring you back to the question, because the stadium
in the other.
I'm not going to ask you about your views as to whether it should have been a devolved response.
But it was.
It was.
Yes.
I'm going to ask you about. That's what it was.
Yes.
It was a public health emergency that was being dealt with in that way.
Yes.
And the aim was to work as effectively as possible, of course.
Yes, and that was
within
my
that framework.
Then that was my experience of it.
Yes, and I want to ask you about the workings of that framework, whether it worked well, whether there are lessons to be learned, and you've made some observations already about that.
Right.
I take from what you've said so far that the understanding of a four nations approach is wider than just everyone does the same. It's everyone does the same, or if they don't, they coordinate and cooperate and communicate. I think you agreed on that.
I think it is stretching the definition of a four nations approach to say that we can have a four nations approach and the four nations do things differently based on the same clinical advice.
So we don't. So
I'm not enthusiastic about that. I don't think that it is constructive. I recognise the constitution and the devolution current settlement, but if I
may, Mr. Hancock, I think perhaps you're straying into the wider issue. I'd like to bring you back to working with the system as it was, and moving on then from definitions about a four nations approach, which leads us down a wider path. I see. I'd like to ask you about the group that you set up, which with your counterparts, and there was some praise for it in the evidence, which I think you've seen, that it worked well, suggesting that it worked well. So you had spotted, as the way you put it in your witness statement, is a missing piece of institutional infrastructure.
Absolutely.
Which was the four nations' health ministers or health and social care secretaries of state getting together in order to communicate in what might be the appropriate way, and I need to ask you about that. And this was also a WhatsApp group as well.
It was.
And in fairness, to set the context, there is a comment on that WhatsApp in the messages stating specifically that it worked well, and appreciative words of the focus and frank discussion that was had in that group, and also in a report which the inquiry has seen from Professor Henderson. There is there a record of a report of that group being positive, a positive experience by one of the other secretaries of state. On the other hand, there is also evidence before the inquiry which comes not from one of the participants, but from Mr. Mark Drakeford, First Minister for Wales, where he makes the general point that his impression was that meetings between ministers were held at short notice, sometimes without agenda or papers, and from views expressed to him by Welsh ministers, that in many cases the UK government called these meetings with the devolved governments in order to inform them of decisions already made, rather than that they were a forum for joint decision making. Now, putting to one side the fact that I understand your general view that things should have been structurally different, but they were what they were, and we know that you wanted to work as effectively as possible to make the response as effective as possible. Can I ask you for your appraisal of those meetings? Were they adequate to provide that missing infrastructure? Was sufficient notice given to the participants so that they could have the opportunity to respond meaningfully on emerging decisions, or were ministers simply being told of something that had been decided and it was simply a matter of telling them that?
All of the above. It depended on circumstances. In the health ministers, sometimes, of course, we'd call things at short notice. And I've, Chair, if I may, a couple of times I've seen in evidence people complain about things happening at short notice. Well, sometimes it was necessary to do things at short notice. And sometimes we had to take decisions. For instance, some of the early local lockdowns, we had to move fast when the data became available. In this case, sometimes I would call short notice meetings. I might even go on the WhatsApp group and say, there's something important come up. Can we find time for this today? And for instance, or ask a private secretary to organise something at short notice. But we also had, in the case of the health ministers, a weekly drumbeat. And more typically, if there was an issue that came up, we would put it into the next week's agenda, and any of the although I chaired the meetings because I have both UK and England responsibilities, anybody would put items into the agenda. And I think actually we changed it so that later on, so that we had a rotating chair of the weekly meeting as well to make sure that everybody was engaged. But I can't commend highly enough Jean Freeman, Vaughan Gething and Robin Swan for the approach that they took. It was, we left the politics at the door. The fact we were from 4 different parties kind of made it that even easier. We cared about what we could learn from each other and what we could do together to save lives. And of course there were moments when there were substantive issues that led to tensions that needed to be resolved, but they'd be resolved in a professional and business-like manner. And I think if you look at Jean Freeman's comment when she left the WhatsApp group as she retired from politics in 2021, there's an exchange, it's a lovely exchange on the 13th of May, which summarises how we all felt about it.
Mr. Hancock, thank you. I've run out of time, so I'll have to stop there. Thank you very much for your answers.
Thank you, Ms Harris. Ms Mitchell, can we fit in your question before we break?
Mr Hancock, I appear as instructed by Amar Anwar and Company on behalf of the Scottish COVID bereaved. I'm obliged to my learned friend, Mr Keith Casey, who's asked many of the questions that were posed by the Scottish COVID bereaved and wish to be put to you. I just want to ask you about one area at the moment, and that is public communications between the UK government and the Scottish government. And I wonder for that purpose if we can have before us inquiry number 94320. This is a WhatsApp group that you were involved in. And if we can have page 3 of that document, please. It appears to orientate us in relation to this matter. This is a document showing text messages taking place as you're waiting for a meeting in relation to Spain and quarantine. And do we see from page 3, two or three notes down, Jamie Njoku Goodwin says that number 10 view as we communicate this ASAP this evening if needed, because it appears that the DFT was asking for 24 hours before communicating it.
Yeah.
If we take it down to where it says owner of the cell phone.
That's me.
Yes, indeed. You say, me too. It will leak anyway, and we heard your views on leaks yesterday, and the Scots will try to get their announcement out first. So my question, first of all, in relation to that matter is, if and when the decision had been taken that was being proposed, what is the issue with the First Minister communicating that to the people of Scotland first?
Well, there were a number of moments when the First Minister of Scotland would communicate in a way that was unhelpful and confusing to the public, and sometimes would leave a meeting and begin communication of a decision, for instance, sooner than agreed. I mean, in contrast to my warmth towards my health counterparts, we then found it much more difficult when decisions went up to First Minister level, particularly with Nicola Sturgeon, because we would find that sometimes some kind of spin was put on what was essentially substantively the same decision. So that was it was a frustration. I've got to be honest about that.
You've made a number of assertions there. First, can I pick up, was there agreements made about the timing which were breached?
Sometimes, as far as I'm aware, yes. But this, of course, my reference here is when there's a decision that has First Minister responsibilities. If we had a discussion, which for me was much more frequent, of course, with at health level, and we all agreed on a communication plan, I have no recollection of any of those being breached.
So you believe that others were breached in relation to meetings that you didn't know about, but none that you did know about?
No, of course, that's not what I'm saying. What I'm saying is it was far more frequent for me to be involved in the meetings with health ministers. But yes, of course, I was in meetings where there would just, instead of a cohesive communication to the UK public about an agreed decision, including decisions agreed across all 4 nations of the UK, there would then be confusing communications, differently put, and that undermined the UK response as a whole, and it is regrettable.
Mr Hancock, were you aware that the UK government's public communications suffered significant problems in being able to failure to distinguish between phrases in relation to England, the UK, this country, and using the term British meaning England? Were you aware of those difficulties?
I was always very careful to try to not confuse these important terms.
Yes, but I'm asking you, were you aware of the difficulties that existed in the UK government's communication?
Not as far as I was involved, no. I would use the term this country to mean sometimes England, sometimes the UK, because those terms are, if you are in the same way that if you're Scottish, this country can mean Scotland and the UK. But in terms of the literal descriptions, I'm not aware of. There's no errors on that I'm aware of.
My lady, I have no further questions.
Thank you very much, Ms Mitchell. We'll break now. I shall return at 25 to 12.
All rise.